Welcome back, everybody, to, believe it or not, the very last lecture of this class. As was foreshadowed in our previous lecture, what we'll be focusing on in this final iteration of the class is two different umbrella categories of mental health disorders, what are called mood disorders and schizophrenia. In reality, we'll be continuing our discussion of mood disorders in this lecture, and then transitioning in the final portion of this class to another grouping or classification of disorders called schizophrenia. Let's start with those mood disorders first. If you remember back to our previous lecture, we spent a lot of time talking about not only the general idea of mood disorders, but one particular mood disorder. What I'm applying here is we spent a lot of time talking about the most prominent mood disorder out there called depression. We looked at some of the symptoms relating to it and some of the nuances to not only some of the things that could possibly bring it out in individuals who eventually get diagnosed with this disorder, but some of the things that can be used in treatment for people struggling with symptoms that qualify them as being diagnosed with depression. I want to reiterate that when we start talking about depression and other disorders, that when we talk about these things and all the different types of disorders, we are talking about symptoms that real people are struggling with. And many individuals struggling with these symptoms also struggle with the stigma associated with diagnoses of these. And this makes this, in particular, a very sensitive and challenging topic to try to address in a general psychology class. It's also important to note that we're not only talking about real people, but when we look at these things from a holistic perspective, we try to understand large percentages of the population and some of the things that people struggle with, the clinical criteria for a lot of the stuff that we're discussing might not be met by many individuals within the population. But that doesn't mean that our understanding of some of the triggers to symptoms relating to these things and some of the options that people might consider, even if they don't necessarily meet the criteria or get past the thresholds relating to these disorders, isn't something that we want to keep in mind. So with all that said, we are going to again continue on in this first part of the lecture by discussing this general classification or umbrella of disorders called mood disorders. In particular, we're going to be looking at three different types of mood disorders that to an extent have similarities to depression. They all do relate to basic emotions and in particular positive and negative affect. But as we're going to see as we progress here, there's subtle differences, or sometimes very robust differences, between the symptoms associated with these disorders and those associated with depression, the one that we talked about in our previous class. And the first mood disorder that we're going to be looking at today is something called seasonal affective disorder. The acronym for this one, SAD, was indeed intentional, and sometimes I think that sort of does a disservice to this specific disorder because it sort of gives this image of people who struggle with this specific disorder as just being kind of ho-hum and sad about things. That's definitely not what clinical psychologists think of when they look at this specific disorder. What clinical psychologists identify with seasonal affective disorder is symptoms when people are at certain points in the month that are almost identical to that of depression. There's the lethargic mood, the lack of motivation, the irritability, the poor cognitive functioning that we talked about in our last class. But what makes this specific disorder unique is the fact that this is a very sort of predictable flow for individuals who do get diagnosed with seasonal affective disorder. Most individuals often report these kind of upswells in these depression-like symptoms during the winter months, and as they get out of the winter months and transition to the spring and summer, these symptoms abate. And this kind of predictable flow between depression symptoms and feeling fairly good happens on a regular basis for people who eventually get this clinical diagnosis. If you look at the chart on the left, you see people reporting how they're feeling in terms of their depression symptoms, at least somebody who would be diagnosed with seasonal affective disorder. And as you see, most of those individuals, at least in northern hemispheres, start reporting feeling fairly good around March, April, and that mood actually stays relatively positive throughout the entire summer. I want to really highlight here that if you look at the left, it doesn't say people feeling manic episodes or feeling overly excited or agitated. It just says individuals report feeling better during those summer phases. That's a really critical distinction that I want to make, because we're going to see another disorder in a couple slides that has that kind of cyclical pattern to it, but not in this same form, and it's not just about feeling better. There's other things associated with something that we sometimes call bipolar disorder. You might hear it getting called a couple other names, but it's usually the clinical term that's used. Seasonal affective disorder, going back to this, is indeed, again, associated with not only change in seasons, but specific regions as well. There's an abundance of research that has shown that the more either northern or southern you get within specific climates, more in particular, the further from the equator you get, the more likely it is for an individual to start displaying symptoms that could get them past the threshold of being diagnosed with this disorder. In the United States, at least in just the main areas of the United States, you can see pretty dramatic rates of kind of diagnoses in individuals depending upon where they're located. Down in Florida, California, only approximately 1% of the population goes through these shifts and displays symptoms that are robust enough to qualify them as struggling with seasonal affective disorder. In northern states like Minnesota or North Dakota, you see those rates climbing to approximately 10% of the population up there, displaying these kind of cyclical patterns that get them past the threshold of being diagnosed with this disorder. This is even actually more robust, and maybe not to a clinical level, but kind of very commonplace when you get to very far extremes, places very close to the North or South Pole. And not only do these things seem to be linked to the light and how much sunlight we're exposed to, but there's actually an abundance of research that suggested that if we can find ways to replicate the light that people are not encountering when they're in these northern or southern regions during their winter seasons, we can actually help curb or kind of at least lessen the extremity of some of the symptoms that people are reporting. And this same light therapy technique, which uses a special combination of UV light, is not something that's effective for somebody diagnosed with clinical depression. It's not a very effective technique, honestly, for many other types of disorders. In fact, it seems to only be a very effective tool for this one specific thing, really highlighting how clinical disorders can very often be intertwined with environmental factors, and in this particular case, exposure to the sun and being outside. And this disorder, even though there are other types of treatments that can help with it, is one that's so sort of intertwined with this. This tends to be the most common and well, the most popular attempt to try to help individuals that do start to report symptoms that fall in this pattern. Another disorder that on the surface sort of looks like depression is something that's nowadays called persistent depressive disorder, or PDD. Now, if you look in historical textbooks, you might see this listed as a different name. One of the names that was commonly used is something called dysthymia. And this specific disorder, kind of like we just saw with seasonal affective disorder, sort of looks on the surface a lot like the first mood disorder we covered, depression. The real unique thing with PDD here is that these depression symptoms that people report when they're diagnosed with this don't tend to be quite as severe as those who are diagnosed with clinical depression. But even though these symptoms aren't quite as robust, what more often happens for these individuals is these milder symptoms of depression last significantly longer. Instead of coming and going like depression typically does for a large percentage of the population who are diagnosed with it, individuals who are diagnosed with persistent depressive disorder tend to report symptoms that are not just for a few months, but oftentimes multiple years. In fact, the clinical diagnosis of PDD only comes about when people report having these persistent depressive-like symptoms for at least 2 years. Now, when we start talking about these nuances to it, I do want to reiterate the fact that clinical psychologists, when coming up with these names and coming up with these criteria, are sort of just trying to categorize these things in a way that allows for common communication and an attempt to try to dissect what's causing some of the problems people are struggling with. There's no magical thing or switch that flicks and leads somebody to eventually develop symptoms that are more inclined to be PDD versus depression. But if somebody's symptoms sort of fit into the criteria for PDD better than depression, people will get that diagnosis. If we're looking at what percentage of the population is diagnosed with it, what we see is about 2.5% of the population is diagnosed with it at some point in their lives, at least that's what most estimates indicate. However, there is some debate on this specific mood disorder as to how common it is. Some have contended that maybe things that could qualify as PDD are actually being diagnosed as depression in some individuals. Others have contended that this might be extremely under-identified, as individuals who struggle with it start to just be sort of associated with that negative mood and start to be perceived more as a type of person than somebody who might require some type of clinical assistance. And all of those things combined create a real challenge for clinical psychologists to not only distinguish PDD from depression, but to really identify it successfully in terms of who should be diagnosed with it and what percentage of the population is struggling with symptoms that best fit into this category. What's really interesting to note with PDD is that even though, by name, it's supposed to be tied to milder symptoms of depression, there's a lot of research that started to suggest that this specific disorder can really eat away at the lives of these individuals in a way that almost makes it more problematic for these people over their lifespan than people diagnosed with depression. It's not as well known, it lasts significantly longer, and again, because these types of symptoms can often be tied to this assumption that it's a personality thing, not a clinical thing, you can oftentimes not only see misdiagnoses, but just not a lot of sensitivity to individuals struggling with symptoms related to PDD. And because of this, there is a real need to continue to assess this specific disorder and to make people more aware of it and how it can afflict an individual's life because of how it manifests itself and all the nuances tied to it. Hopefully through this lecture, you are now one of the people that is a little bit more aware of this very problematic disorder for individuals. And this brings us to our last mood disorder that we'll be discussing in this class. It's something that is very unique in terms of the symptoms linked to it and how it manifests itself in comparison to the other mood disorders that we've talked about. Mood disorders tend to focus, if we're looking historically at them, on negative moods, and bipolar disorder, which you'll also see sometimes listed as manic depressive disorder, does oftentimes have these depression-like symptoms tied to it. But what makes bipolar disorder a very unique mood disorder is the specific types of affect that are sort of unique to bipolar disorder, these things that we call manic symptoms. Individuals who report manic symptoms don't often report feeling extremely happy or blissful. Well, sometimes they can, but that's not the typical thing that pops up when we talk about manic symptoms. Instead, it's just an extremely active mood that these individuals report. They tend to be more uninhibited when they're experiencing manic phases, oftentimes more agitated, and their train of thought just tends to get little disjointed. Individuals who struggle with manic symptoms alone oftentimes just get diagnosed as being linked to bipolar disorder. There are, however, variations in extremeness of these manic symptoms and in the prevalence of the depressive symptoms that has pushed clinical psychologists to kind of qualify bipolar disorder into different categories. Again, not necessarily because there's a specific code that all people have to meet, but just so clinical psychologists can talk about this in a way that sort of helps those individuals struggling with these problems to be better understood. Those individuals who've had at least one, what we call sometimes full-blown manic episode, or just one to the point where they really are crossing a specific criteria, a threshold for a criteria, those individuals are diagnosed with what's called bipolar type 1 disorder. Now, some with bipolar type 1 can experience kind of more depression symptoms than most. Others can experience very mild depression symptoms, and some could just be experiencing these what sometimes are called full-blown manic experiences. Anybody who gets to the criteria of experiencing a full manic episode tends to get diagnosed with bipolar type 1. If the manic episodes are a little bit less robust, if they're qualified as something called hypomania, then somebody could be diagnosed with two different types of bipolar disorder. If that hypomania is paired with severe depression symptoms, granted this is not happening simultaneously, this is something people fluctuate between either on a daily or weekly or sometimes monthly basis depending upon the individual. If that hypomania is paired with severe depression, most of these individuals will get a diagnosis of bipolar type 2. If somebody's experiencing both milder manic symptoms and milder depression symptoms, but they're going through these cycles that are the definition of bipolar disorder, then they're often diagnosed with something called cyclothymia. It's not a perfect formula to put somebody into one of these categories, but these terms, these definitions, do again help clinical psychologists better assess and kind of discuss some of the challenges that people with bipolar disorder, diagnosed with bipolar disorder, might potentially struggle with. In all of these different categories, though, it's important to note that this, out of all the mood disorders we've covered so far, is by far the most rare. It's also one that tends to run in families significantly more than most disorders that we've talked about. It's not that there aren't genetic links to almost all the disorders that we're going to cover in this class, but the genetic factor seems to be particularly high for bipolar disorder. And unfortunately, for individuals who are diagnosed with this tends to be sort of a lifelong thing. And this is where treating this specific disorder starts to become a sort of controversial and problematic thing. Many individuals who are diagnosed with bipolar disorder tend to be placed on some type of drug regimen right off the bat. The drugs that are most commonly used today are called mood stabilizers, and there's lots of different combinations of mood stabilizers out there. So one of the first challenges with bipolar disorder, if somebody's willing to take medication, is to sort of find the right drug combination that helps with not only the manic episodes, but if needed, also the depression episodes. And also trying to convince somebody to sort of stay on those drugs as they cycle through the different phases of mood is oftentimes a big challenge. And this has led to lots of research looking at not only how clinical trials of drugs can be helpful in understanding how to treat bipolar disorder, but how specific techniques, either ones that exist on their own or through combinations with drugs, can help individuals that do cycle through this very atypical disorder that is bipolar disorder. And honestly, it's an ongoing experiment. It's something that researchers are really trying to understand better. with the recognition that everybody's going to be unique and there's going to be different types of challenges that need to be addressed with each specific person. Fortunately, with bipolar disorder, as the research is moving on, there is theoretically a way to help a large percentage of individuals struggling with this fluctuation between moods. And that makes this disorder something that, well, is considered a lot more manageable for individuals struggling with these symptoms if the right circumstances are raised. It's always a challenge. It's a very tough one to look at for people struggling with it because of this just kind of persistent struggle that goes along with it. But it is one that, out of all the mood disorders, I'd like to close out with because of how promising some of the advancements have been in our understanding and our ability to help individuals with this specific, very kind of catastrophic for them mood disorder. Now, with covering these 3 disorders that we've covered today, we've sort of reached the end of this classification or this umbrella of disorders that we call mood disorders. Much like we saw with the anxiety disorders we covered in our last class, each of the different disorders kind of fitting under this umbrella have some things in common, but there's also a lot of unique nuances to all of them. Your job as you're studying them and trying to understand these a little bit better is to make sure that you really can distinguish them from each other, know a little bit about the statistics tied to them, and understand a little bit about the research around things like treatment and the sources of them. When you do that, then hopefully, again, you're well prepared as you move on if you do decide to take future clinical classes or other classes that might utilize this information. And this allows us to then turn on to our last topic that we're actually going to cover throughout the entire class. And that last topic is a very sensitive one, so I really want us to slowly work our way through it. It's a disorder called schizophrenia. Unfortunately, out of all the mental health disorders that you can see in clinical psychology, I think this is probably the one that's sort of misrepresented the most and misunderstood the most in the everyday population. If you watch television shows or movies or see newscasters talking about this, oftentimes schizophrenia is intertwined with a wide range of different mental health issues. In movies, it's often linked to something called multiple personality disorder. In stories, it's linked to sociopathic disorder, or people kind of enjoying the pain of others. Antisocial personality disorder, this kind of disconnect, this not wanting to be around others, also is a very common theme that pops up with schizophrenia in numerous resources. But that's really not, if we're looking at it from a clinical perspective, what schizophrenia is all about. By definition, people who are diagnosed with schizophrenia are experiencing some type of severe disconnect with reality, either on the cognitive or the emotional level. But this disconnect for individuals can vary dramatically from person to person and in terms of the symptoms that are manifested in individuals diagnosed with schizophrenia. But for almost all people who are diagnosed with it, this is, much like bipolar disorder, a lifelong challenge, because their main focus, their main struggle, is to be able to sort of distinguish between this altered reality that their mind is trying to convince them of and the real reality that they're encountering. Something that is very daunting for individuals diagnosed with schizophrenia, regardless of the specific type and severity of the symptoms that they're encountering. And this brings us to the big thing that I want to focus on first when talking about schizophrenia, and that's the symptoms that are tied to this disorder. When we talk about people diagnosed with schizophrenia having some type of break from reality or inability to process the world around them in a typical manner, that could lead you down a lot of paths. And honestly, if you look at the population of people diagnosed with schizophrenia, there are lots of paths that people take. So what clinical psychologists have attempted to do when trying to understand schizophrenia better is classify, define a lot of the different symptoms that fit under this broad category of schizophrenia. One of the ways that we do this is to categorize the general symptoms into 4 different groupings. The first grouping is something called positive symptoms. On the surface, that name might imply to you that these are the things that these individuals have going for them, or the things that are desirable for them. It's not necessarily the case. In fact, it's usually not the case. For individuals who start to manifest positive symptoms of schizophrenia, what that means is they're displaying thoughts or behaviors that are not part of a typical person's repertoire. Negative symptoms are sort of the opposite of positive symptoms. These are symptoms that these individuals are diagnosed with because their thoughts or behaviors that they're displaying are sort of lacking in comparison to a typical person's behavior. We're going to define these a little bit more closely as we progress and look at specific types of positive and negative symptoms. But I always want to start with those 2 because, 1, the names don't always intuitively lead you to what they are. And 2, these tend to be the most commonly identified things when we talk about schizophrenia. But there are 2 other groupings of symptoms in schizophrenia that are really important to also discuss. One of them is sort of a byproduct to some of the other symptoms out there called cognitive symptoms, where just the basic cognitive skills, memory, organization, attention, start to get discombobulated for individuals struggling with a multitude of other schizophrenia symptoms. It also tends to lead to other types of symptoms that we call affective symptoms, where because of some of the positive or negative symptoms that these individuals are having, or maybe even some of the cognitive symptoms that these people are experiencing, affect starts to get impacted as well. And this could be in a variety of different ways depending upon the types of positive, negative, or cognitive symptoms that these individuals are experiencing. Again, we're going to get a little bit more specific with these last 2 as we progress, but I want to first focus our attention on those positive symptoms because these are the most commonly associated symptoms with schizophrenia. So what are the typical positive symptoms of schizophrenia? And when we're looking at positive symptoms of schizophrenia, we're looking at either behaviors or thought patterns that these individuals are displaying that aren't part of a typical person's repertoire. The most common positive symptoms, at least in terms of diagnoses, are hallucinations and delusions. Hallucinations are sort of about our sensory systems being activated and sort of tricking our brain to experiencing things that aren't actually there. Technically, hallucinations can exist in any form in terms of our systems of our sensory systems. So that's touch, vision, taste, smell, all the ones that we've covered already. But the most common ones that occur for individuals diagnosed with schizophrenia are auditory and visual. Actually, auditory ones are much, much more common than the visual ones if we look statistically at people diagnosed with this disorder. Individuals diagnosed with hallucinations report large arrays of different types of hallucinations they're experiencing. Some report hearing voices, others report seeing things that aren't there, others report a whole array of combinations of sensory data that sort of throws them off and gets them to really try hard and often struggle with distinguishing reality from what their sensory inputs are telling them. And for a long period of time, there was this assumption that a lot of this was sort of just imagined by these individuals. It was anticipated, but not something that was at the cellular level. Recent research, well, relatively recent research, has suggested that this is sort of an incomplete and inaccurate assessment of where these hallucinations are coming from. Numerous studies have shown that at the cellular level, when people report hallucinations, their brain is essentially receiving signals that make it very challenging for them to distinguish from what their brain is kind of picking up on that's not there and what's actually there. And it gives us a better insight into why once hallucinations start for individuals who are diagnosed with schizophrenia, it's very tough for them to sort of ignore them or overcome them. This is also true for the other very common positive symptom of schizophrenia called delusions. Delusions aren't about seeing, or hearing, or experiencing some type of sensation that's not there, but instead, this is about the thoughts or beliefs that these individuals start to form that are not only rigid, but extremely unfounded. Now, I know when we talk about this in this day and age, this might lead many of you to believe that those that have different opinions from you or different beliefs about stuff should be diagnosed with schizophrenia. That's definitely not the case. When we're talking about individuals diagnosed with schizophrenia, what we're looking at is individuals who are struggling with not just kind of going down a rabbit hole and trying to believe something, but instead with very extreme, very oftentimes troubling thoughts and beliefs that make it very challenging for them to function on a day-to-day basis. One of the more common delusions that individuals with schizophrenia report are these things called delusions of persecution, where they think either a specific group or a specific collection of individuals are somehow conspiring to persecute or kind of harm the individual that's experiencing these delusions. These delusions of persecution can be on their own, or they can be paired with other delusions that these people experience. One of the common ones that's paired up with it is something called a grandiose delusion, where somebody believes that they have either some special importance or some unique sort of out of this world skill or ability that puts them into a completely different category than other individuals. Now, these grandiose delusions, when paired with delusions of persecution, can become very problematic for individuals struggling with them. It can cause them to experience, as we're going to talk about later, a large range of different emotions that can manifest themselves in different ways. And trying to address the specific delusions that people are experiencing and how to help them overcome some of the delusions is a pretty big challenge for people struggling with schizophrenia. To add to the delusions that are out there, I also wanted to include another one that's very common called the delusion of reference, where people diagnosed with schizophrenia start to tie things together in ways that don't follow the typical cognitive patterns that we would use to kind of make connections between things. You might have seen in movies individuals pulling out words from newspapers and creating a phrase from them, or connecting stories and headlines with random pieces of string to show that there's all these grand connections between ideas. And I want to highlight how that specific type of delusion of reference can exist, but it's, again, sort of a misrepresentation of some of the delusions of reference that individuals experience. They're not always tied to grand schemes or specific things that these individuals assume have to be true. Oftentimes these delusions of reference sort of pop up randomly and are really tough to trace back to where they came from. But when combined with a large number of other symptoms, they can start to create a very chaotic, problematic experience for individuals who do struggle with these positive symptoms of schizophrenia. As I mentioned earlier, positive symptoms of schizophrenia are, of course, just one type of symptoms, or category, I guess, of symptoms of schizophrenia that are out there. There's also individuals diagnosed with schizophrenia that experience more of what we call negative symptoms of the disorder. Individuals diagnosed with schizophrenia who are displaying negative symptoms can, much like the positive symptoms, display a wide array, or actually not display, a wide array of things that a typical person does display. The most common negative symptom of schizophrenia is kind of an internal and external thing. Usually, people diagnosed with schizophrenia, if we're looking at their affective issues, if it is kind of negative in nature, report sort of blunted emotional experiences. They don't necessarily have no emotions when they're encountering things, but they sort of report a lessened emotional range as they're experiencing day-to-day things. And this sort of lessened range of emotions tends to manifest itself outwardly in facial expressions, in communications, and tone, and other subtle things that we sort of take for granted if we are experiencing a typical range of emotions. When looking at the outward manifestation of these negative symptoms, clinical psychologists call this sort of lack of range of emotions blunted affect. And when other issues like the delusions and hallucinations we talked about come up, other negative symptoms can sometimes follow, like sorts of social withdrawal, where individuals start to kind of get away from people or away from social environments, and poor self-care, where individuals start tending to the delusions or the hallucinations more, and in doing so, sort of turn their attention away from the day-to-day things like grooming and just basic hygiene in terms of sleep hygiene, physical hygiene, and other things that really do help individuals thrive. So when somebody is displaying these types of things, again, they get defined as experiencing negative symptoms of schizophrenia. So it doesn't mean these are the negative ones, the bad ones. It just means these are the qualified symptoms that get put into this category. Not all people display these, but when they do, this is the category for them. The other types of symptoms that are out there, again, are kind of more broad, overarching. There's the cognitive ones that focus on, as the name implies, our cognitive functioning. Language, thought, attention. These are the main things that we focus on when talking about the way cognitive functioning can be impacted by schizophrenia as well. And this is something that often is actually identified first in many individuals struggling with schizophrenia. Their pattern of speech can become very kind of atypical. Their ability to connect ideas, to make sense, starts to become frayed or problematic. And basic memory and of emotional experiences of things, well, actually not emotions, but memory and kind of understanding of things starts to sort of get off for individuals diagnosed with schizophrenia. Now, these things don't necessarily have to be there for individuals to be diagnosed with schizophrenia, but oftentimes things like language issues, the ability to kind of focus and make sense does become a challenge for many individuals diagnosed with schizophrenia. And these specific problems are put into the category of cognitive symptoms. If somebody's experiencing mood issues that oftentimes get tied to schizophrenia, well, then this gets tied to the category of affective symptoms. There's a lot of comorbidity between depression, anxiety disorders, and schizophrenia. Now, these symptoms can just be a diagnosis on their own, or they can get put into the affective symptoms category as sort of a component of schizophrenia, not a separate disorder that these individuals are struggling with. But when looking at these affective symptoms, it's important to note again that it's very common for individuals with some of the positive and negative symptoms that they're experiencing, along with the cognitive symptoms that we just talked about, to experience some type of affective issue. It's not necessarily extremely common to see people who are experiencing both blunted affect and severe depression, but it's possible, and there are individuals who do experience kind of a wide array of different affective experiences as a result of their diagnosis of schizophrenia and their specific symptoms that they're struggling with. And this long journey we sort of just went on with schizophrenia brings me to a really important note when we talk about schizophrenia. And that's the fact that pinpointing exactly what type of schizophrenia, what classification of schizophrenia somebody is struggling with, is a real challenge in the clinical community. There is an attempt, as you can read about in your book, to classify the combinations of symptoms that we've talked about into different types, with the hope that, again, by typing somebody and their symptoms, we can better understand some of the challenges they're going through and some of the paths to helping those people. But not all people fit into the perfect category when talking about schizophrenia. So some individuals might just get diagnosed with schizophrenia by meeting a certain threshold. In particular, the DSM, that's the manual used in the United States for clinical psychologists, requires that an individual to be diagnosed with schizophrenia needs to not only display a deterioration of their daily activities, but at least two of the symptoms that we've covered so far. Even though if hallucinations or delusions are severe enough, nothing else is really required to get diagnosed with schizophrenia. Out of the entire population, what we tend to see, at least across most of our developed cultures, is around 1 to 2% of the population at a given point in time is diagnosed with this disorder. That's a much lower level than most of the disorders we've talked about. In fact, the only disorder that's really close in terms of the numbers to schizophrenia is bipolar disorder. And actually a lot of the nuances to bipolar disorder are there in schizophrenia. We see no big necessarily categorical factors tied to it. Gender does sort of matter to this, in that men are diagnosed slightly more than women on this one. And groups and childhood struggles and other things have been tied to this disorder. But being able to tease apart things like early drug use and traumatic experiences and gender or socioeconomic status or education levels is a real challenge for people in clinical psychology. The only thing that we've really been able to do when looking for who is a penchant for being diagnosed with schizophrenia is tie it to specific genetic factors. In particular, what we've seen in numerous twin studies and other heritability research that's looked for specific genes is that there is a big tie, a strong tie, between schizophrenia and the genetic combination that we're born with. However, this is where we're still trying to understand this topic better. What we've seen is that knowing a person's genetic markers is insufficient to being able to predict if somebody will eventually develop symptoms of schizophrenia in their late teens or early 20s, when this disorder typically manifests itself in individuals. What researchers have tried to do, once we've understood this link but realized that it's not absolute, is look for things that could put people who have a genetic proclivity for developing schizophrenia sort of on the path to having these symptoms start to emerge. Some have looked at individuals on the structural level, looking for brain abnormalities that might not only exist when symptoms of schizophrenia are starting to pop up, but things that are starting to emerge as they age. We know for individuals who start to display symptoms of schizophrenia, especially as they become more robust, they have specific structural things within their brains that starts to be unique. It's almost impossible to see it usually for most individuals with the naked eye, but if you look closely, and you've got a trained eye, there are structures like the ventricles and the hippocampus, and the amygdala, and other areas that do show irregular structure when somebody is experiencing symptoms of schizophrenia. There's also, at the cellular level, a lot of disarray in the cellular connections that are not typical of most individuals who aren't experiencing symptoms of schizophrenia. But what's causing these things to emerge? Whether or not we can forecast the development of schizophrenia symptoms as somebody starts to age and their brain starts to deteriorate or kind of change is not something that we've really been able to master. And this has led people down a lot of different paths, trying to figure out what can be used as an indicator of how the brain is going to shift and how genes do play a role for some individuals and not for others when we talk about the manifestation of schizophrenia. One of the old theories that started to pop up was that maybe this was something that was sort of kind of a precursor to early development. In fact, such a precursor that it might be something that's really a byproduct of something we encountered in utero during the second or third trimester while our mother was encountering the world around us. There was research on maternal stress and diet and exposure to specific chemicals that was trying to find different combinations of factors that could be precursors to the development of schizophrenia. There's also a lot of research that's today looking at this diathesis stress model that suggests that maybe certain stressors and problems people encounter could lead to the development of schizophrenia if somebody has a predisposition for it already. But it's important to note that with all of this research on the brain, exposure in childhood, stressors that people are experiencing, encounters with specific environmental factors, that there is no silver bullet that we can use to predict exactly when somebody's going to develop symptoms of schizophrenia and when somebody's not. And this has led people to continue to try to assess and understand this as the field is growing and as we're getting better and better with our research tools that we have at our disposal. Now, in addition to there being a lot of complexity to the sources and the symptoms linked to schizophrenia, there's also a lot of complexity to treating schizophrenia. Depending upon the symptoms that people are experiencing, combinations of mental health therapy and medication might be prescribed to individuals. For other people, if there are specific symptoms that they're struggling with, medication, sometimes called antipsychotic or neuroleptic drugs, might be prescribed more than some type of talk therapy. But what we see with schizophrenia is regardless of which technique is first used, treating individuals who do struggle with this lifelong thing once the symptoms start to emerge tends to involve sort of adjustments and tweaking and trying to find the right combination for individuals as they're manifesting their symptoms. And as a result of this, that there is this kind of persistent need for people who are diagnosed with this to assess what's working, what's not, and what's manifesting itself in these individuals struggling with this disorder. Compare that with the fact that some of the early treatments of this disorder had some nasty side effects, some of which are listed at the bottom of this slide. And we see a story when I'm talking about treating schizophrenia that's very complex and just sort of adds to the litany of struggles and things to consider when we talk about this very problematic disorder. And to understand how this is even more complex, we have to appreciate that for many individuals struggling with symptoms of schizophrenia, most drugs, at least most antipsychotic drugs, do tend to have a pretty robust effect right off the bat. But as time passes, many antipsychotic drugs start to see their effects wane. And this is why you'll often hear when people talk about treatments for schizophrenia, especially on the medical side of things, that finding the right drug and the right combination, sometimes of clinical work and drugs, is essential to helping these individuals who are struggling with a very multifaceted disorder. Unfortunately, this, because it's a lifelong thing, will require oftentimes constant assessment and tweaking and adjusting as things start to emerge throughout the lifespan. But if we're looking for a silver lining on this, it's important to note that research is getting better on this. And many drug and therapy combinations, when used together, can help a large number of people struggling with these very problematic, troublesome symptoms of schizophrenia that we've talked about. All right. I think ending on that positive note of schizophrenia and this mention of lots of research that's still being conducted, not only on schizophrenia, but many different areas of clinical psychology and in psychology as a whole, is a great place to not only end this lecture, but to end this class as a whole. It doesn't necessarily mean that I am going to be completely gone. I will be readily available via email, or if you want to try to set up a meeting with me on something like Zoom. But just keep in mind that as we reach this finish line here, you hopefully have now really accumulated a vast array of information that covers not only a couple snippets of topics within psychology, but the field as a whole. And I assure you that if you do move forward and take future psychology classes, you should feel, if you've done well in this class, very well prepared for anything that comes at you in those future courses. But for today, I am going to bid you one final adieu with this last send-off. Wish you all the best again, and I hope to see many of you at some point, somewhere along the way in your lives or careers. Take care, everybody.